background work I've done includes looking at imaging biomarkers in sarcopenia for cancer because we're the computational oncology lab, and I'm very aware this field is much bigger than what is just in cancer. So what I'll be talking about is just looking at sarcopenia from non-cancer viewpoint and also from a cancer viewpoint, and then talking about why we're particularly motivated to do this in cancer because of the availability of imaging in oncology. And then the results of a scoping review that's ongoing, where we've looked at who uses what kind of biomarkers for what kind of studies, and the applications of these, and maybe some future work. So, sarcopenia in cancer, or sarcopenia precedes sarcopenia in cancer, and background comes from a sort of a geriatric perspective mostly, and this sort of overlaps with the frailty syndrome a fair bit. If you look at the European Working Group, they have very specific definitions now, where low muscle strength as assessed by functional tests indicate probable sarcopenia, which can then be confirmed diagnostically with various modalities of imaging, etc. The most commonly used sort of population-based methods tends to be the dual energy X-ray absorptiometry or bioelectrical impedance. They do go on to mention cross-sectional imaging, including CT and MRI. But this is less explored in this population, and unlike DEXA and BIA, they don't have definitive cutoff points. And then severity of sarcopenia is indicated by the ability to perform other specific tests and physical battery tests and gait speed, etc. So that's from the non-sarcopenia background, and this has sort of been co-opted by us. So just a very brief cut and paste from their criteria. These are what they would define as cutoffs for sarcopenia, and the main thing to notice here is that there is no cross-sectional imaging cutoff. There's not been a consensus say, all right, CT of this limb showing this means sarcopenia, or MRI of this limb shows sarcopenia. So that's lacking. And if you look at the other working groups, so that the European group that we've just touched on, there's also the Asian working groups, which looks at exactly the same sort of battery of functional tests, and also imaging tests, including the DEXA scans. And this is many of the limbs. I suspect that's partly for ease, and also to minimize the already low dose of radiation that's involved in a simple DEXA scan. Again, there's the lack of CT scans, there's a lack of MRI scans, which we as oncologists are used to performing on a regular basis. The international working groups criteria are a little bit more outdated, but again, echoes what the other two groups have said. So from our perspective as oncologists, sarcopenia and cancer has historically been part of what we call the cachexia syndrome. This is the wasting that you see in cancer, and especially in advanced cancer. It's not limited to muscle alone. You have wasting of a combination of muscle and fat mainly, and it's linked to weight loss predominantly. And thus, we're a bit late attendees to this party, but we've come where our tools have already preceded the concepts. We used to see scanning, whereas sarcopenia as a concept seems to be something that was further investigated with the use of DEXA and BIA in the non-oncology setting. In cancer, there is a need to image our patients. Most of the cancers are what we call solid malignancies. So these are lumps that can spread and grow and be measured and be detected on scans. So scans are useful to look at what the original tumor looks like. So that's tumor specific imaging, and depend on where your tumor is. So you can see a scan of a brain at the top. That's an MRI scan of a brain, and that abnormal thing on the right is a brain tumor in the brain. And then at the bottom you can see a PET scan where it's nuclear medicine scan, so you have a whole body scan and you get a radionuclide tracer, and that's combined to see if a cancer from somewhere else has spread elsewhere in the body. So you have tumor-specific scans and you have staging scans, and these are mostly CT scans. There is some tissue that's better visualized with MRI, so that there is a prevalence of that as well, but majority of tumor imaging will be CT based. And there are various stages during a cancer journey that's where there are imaging opportunities. So you have diagnosis, where you have baseline investigations. You're trying to decide if the patient is curative, so you want to make sure that it's not been spread elsewhere. And then you have, at various points of treatment, you want to make sure they're responding to treatment, or if they're not, that you're changing track. And then after treatment finishes, you might have a period of monitoring where you want to keep an eye and make sure the cancer is not coming back. So you can imagine there, depending on which cancer type and what kind of approach you're taking, there are a myriad opportunity of investigating with cross-sectional imaging. So the nomenclature is slightly different in what I would call oncosarcopenia versus geriatric sarcopenia. And because of the availability of imaging in the literature, certainly you'll see that in cancer there's more of a objective marker from imaging. So we're talking about the size of muscle, quality of muscle, whereas in geriatric sarcopenia there's a greater emphasis on functional tests. These are things like those getting up and walk tests and hand grip strength, etc., which isn't routinely done in clinical practice. So we had a look to see what is available in the literature in the cancer setting. So we had a look from up until June 2000 this year through all the main databases, and we looked at cancer-specific keywords and muscle-specific keywords. And then we had a look at references and extracted those as well. So you end up in the oncology literature with something like 5,500 initial hits, and then after we did title screening and full text screening, we ended up with just shy of 500 studies. And if you look at the results of where people are measuring sarcopenia, the vast majority are in the abdomen. You get a bit in the brain, bit in the neck, coming from the head and neck cancers and the brain cancers. You get a bit in the thorax from various, but including the lung cancers. The majority is in the abdomen. There are many reasons we'll potentially come on to later on. And then you got a smattering of other things. And this is just cross-sectional imaging, so this is not sort of the DEXA scans. This is the CTs and MRIs and PET scans. And if you look at the sort of study populations, so you got the majority, it's very positively skewed, and the majority of studies are in the short hundreds range size-wise. You get about 13, 15 studies that are over 1,000. Some of those overlap. So you get a handful of larger study populations. So the majority are, as you can imagine, single center. We've got this cohort of patients. Let's run this investigation on them. Let's see what they show. And in terms of what kind of cancer type we're dealing with, you get an overrepresentation of the gastrointestinal cancers and the hepatobiliary cancers, far more than you would expect national statistics in terms of prevalence. You can imagine there's a lot more people. So, for example, urology is actually underrepresented. There's a lot of prostate cancer out there, but they don't tend to get as much cross-sectional imaging with CT. A lot of that's done through MRI, for example. So that might be one of the reasons here. But so lots of abdominal tumor radiological biomarkers, and a lot of GI studies, which sort of go hand in hand. And then you get a mix of whether they're advanced or local, so generally speaking, whether you're trying to cure them, and whether they're having surgery versus whether they're having palliative treatments with options of chemotherapy, immunotherapy, etc. Most of the studies are looking at survival. You get a few studies that look at other things as well, so the numbers won't add up because studies will look at multiple things. Survival, progression-free survival are the main things, because a lot of these studies are done in patients who are just about to have surgery for their cancer that's just been diagnosed and they've had a scan at that point. You get a fair amount that look at post-operative complications as well. And then there is the dedicated cohort for oncological toxicity, which is both radiotherapy issues, chemotherapy issues, for example, dose reductions or toxicities. Just arbitrarily divided the studies into originator and secondary studies. The originator studies are the ones where they've analyzed their population and try to derive some kind of cutoff or definition of what sarcopenia is, and then the secondary studies are the ones that try to apply that in somehow. You can see that there's a variety of statistical methods, optimum stratification and ROC analysis to derive a binary cutoff, and then you've got arbitrary methods where they have just taken, all right, what's the median, let's put it there and let's see if it's significant. And then a smattering of a few other things. So what we're having, because the majority of studies look at the abdomen, and the majority of studies in the abdomen actually look at something called the L3 skeletal muscle index. This is a slice through the abdomen, an axial slice through the abdomen at the level of the third lumbar vertebra, and you measure all the muscle in that area, and you tally that up, and you usually divide that by height squared as similar sort of an approach for a BMI, etc. We looked at what these studies try to predict, and I suspect there's a bit of publication bias coming in, but a majority studies are significantly predicted for overall survival, and in the ones where they specifically look at post-operative complication and toxicity, because you have to adjust your methods of optimum stratification towards a specific endpoint. So you can imagine there might be problems later on, as if you're trying to derive a sarcopenia cutoff based on survival and trying to use that to predict, for example, toxicity or post-operative complications. And then we had to try and look at if these populations are geographically comparable. So as we've seen, there are various multiple working groups, the European Working Group for Sarcopenia, Asian Working Group for Sarcopenia, and that's because everyone's intuited that body types differ across geographical locations and populations. The main takeaway here, we noted that is that in Asia, people tend to have smaller amounts of muscle, basically. So again, that can be relevant, as some studies apply a European cutoff to an Asian population, etc. And similarly, if we look at, is there much difference in the cancer population, that seems to be less significant than the demographic one. So here we're looking at tumor types. So are the different body types similar across the different tumor locations? And again, female, male, left and right side. You can see that there's minimum difference from the originator studies. So if there's definitely a sex difference, so that's important. And like some studies have grouped both sexes into one. But actually, that's probably the main takeaway point here. Men are bigger than women in terms of muscle size. So in terms of the secondary studies, and this is looking at we're taking a cutoff derived from another study and trying to apply it in our population. The majority of applied cutoffs come from a small handful of studies, and and it's these. So Martin and Prado are the main ones. Ferron that's a publication on cachexia and standardization of cachexia cutoffs, and they are actually they're cut off from sort of the same group. So it's worth talking about these a little bit more. Sorry for this slide being a bit wordy, but it's a bit of a background on the L3 skeletal muscle index and why so many studies seem to be using it, and the importance of the few studies that everyone's quoting. So this is actually the same group that's doing all of this work. It's a Canadian group, and it started in 2008, where sort of proof of concept in 50 patients, mixed population lung and GI cancers. They managed to correlate various anatomical landmarks to DEXA-derived whole body fat-free mass. And you get correlations of 0.9 from the L3 skeletal muscle area. So that drove the interest for using that as a repeatable, identifiable biomarker that can be applied. And some of the earlier work was done from this Prado study 2008, and that specifically isolated obese cancer patients. So these are obese Canadian mixed GI lung cancer patients. And you're deriving cutoffs from those, and in that the prevalence was 15% in terms of sarcopenia. They used optimum stratification on survival. They derived some cutoffs, and they say 15% of our population was sarcopenic, and this was significant. And then Martin, in the same group, expanded that to non-obese population. So you've got 1,400 and some patients, and again, same cutoff L3. And here they went a bit further and stratified it via BMI. So if you're obese and you're a man, you have a different cutoff from if you're a man and you're not obese, but women, they didn't find any difference. So here you find that the prevalence differed in the non-obese versus obese population once you're looking at a bigger population. So that's where the majority of the sarcopenia definitions come from in the oncology literature. So then we try and see if, okay, this can be, we can transfer that, generalize some of these cutoff points to other studies. So if you look at the studies that exclusively quote the Martin cutoffs, so these are the latest one from the 1,400 mixed population, you see majority of them report on overall survival. And actually, if you're looking at the originator studies where there were 80% of them were finding positive correlations, here that drops off significantly. And we haven't looked into exactly why. There's a very heterogeneous group of studies, populations, etc. But you know, that's worth considering, and the fact that these cutoffs may not be universally applicable. So cutoffs can be derived from many places, and in the Asian studies, they particularly noticed that, okay, maybe obese Canadians aren't the best reference for us, so they've gone and found a lot of them are quoting, especially the Korean studies, as you can imagine. There are national surveys, they measure DEXA scans, and they've used a conversion from the original 2008 Motsakis study, which borrows from the geriatric sarcopenia definition of 2 standard deviations below normal as being sarcopenic, and they use a conversion equation to that relates the L3 to the DEXA-derived values. And you have 7 Korean study and 1 Japanese study to look at that. And again, they mainly look at overall survival. And here, if you, for example, take your own demographics cutoffs, slightly more of them were positive studies as such. There are then a few studies that have also recognized this problem and said, okay, so there are different cutoffs all over the place. Let's apply some of these cutoffs across the board. Let's see. Excuse me. Let's see what might be applicable. And again, here, I think what we're seeing is that the cutoffs from one study isn't universally transferable. So you've got the ATA7 study. They looked at the cutoffs from Prado, Martin, and another study looking at also at ovarian cancers in Kumar, and they found that it was not predictive for overall survival. And you can see in terms of the percentages in the table, that's the prevalence of your population that's sarcopenic, depending on the cutoff that you're applying. So you can see quite a range, and why some of it might be important, especially in the WU study at the bottom, where they are taking 150 pancreatic patients compared to in the obese cancer population from Canada. You can see that if you apply those cutoffs, 66% of your population is sarcopenic, and that's not predictive for overall survival. But then they took a Japanese, it's a Taiwanese originated Taiwanese study, and if you take Japanese cutoffs for sarcopenia derived in a similar fashion, 11% of your population is sarcopenic, and that's predictive. So not all of these are transferable, and it's important to bear in mind, particularly across the demographics. There's a handful of longitudinal studies, and again, the methodology is very heterogeneous. These seems to have, so they report losses in terms of muscle, and that can range from 2 to over 10%, and from 2 months to over 2 years. A mix of findings. Majority seem to find that this is predictive for something, so it's something to bear in mind as well. But because the methodology is so heterogeneous, it's impossible to group them together. So having a look at the oncosarcopenia literature, the main takeaway messages, I think, are these. The L3 skeletal muscle index is the most prevalent biomarker. A lot of cancers image the abdomen, so it's easy to access with the right tools. And because this is at the level of the abdomen, some tumor groups are underserved. For example, if you look at the brain cancer population, where we have a particular interest, we don't tend to image the rest of the body. Cancers in the brain tends to stay in the brain, so you end up losing the ability to do that in the brain population. And I think another message is population-specific characteristics must be considered, finding the right cutoff for the right population. There's a lack of standardization. I think it's impossible to standardize still, because all of these studies tend to be single centers, very few are multi-center. So you're really looking at isolated populations and deriving cutoff from isolated populations. It's very hard to generalize beyond that. If you look at systemic reviews of oncosarcopenia, specifically, they tend to look at specific tumor sites and aggregate all the studies in that tumor sites. Again, you get the mix of the Japanese studies applying the European studies with negative findings, and the European studies that are slightly more positive. So the methodology is inconsistent, and that's not something that's often touched on either. And then longitudinal data probably is powerful, but it's again harder to collect. There's a lack of standardization between what time points and what you're looking at, and then you have the additional issues of it being retrospective and the survival bias. So it's less powerful than a tool that you can have a diagnosis with one scan, and you say, all right, your cutoff is this, and therefore your risk of toxicity, survival, etc. might be affected in some way. So in terms of future work, and some of this is already ongoing, there are a lot of studies amongst the ones that we've looked at in the scoping review that look at other aspects of muscle. So we looked at mainly muscle volume. Studies are looking at muscle quality, and in CT that tends to be with cutoffs of Hounsfield unit in terms of muscle attenuation to consider sort of fat infiltration, etc. And then there's a majority of studies also incorporating fat, because again, from the oncology point of view, the cachexia phenotype incorporates fat wasting as well. I think there's a need to try and standardize things rather than just use the most common imaging biomarker. So although everyone's using the Martin and Prado biomarkers, you're finding that the studies aren't always predictive. We need to factor in demographic considerations particularly, and you might need European-specific sarcopenia cutoff, for example. So in order to do that, I think we need multi-organizational buy-in cooperation and perhaps the need for an Oncosarcopenia working group.
Thank you very much, James. I noticed, I just want to flag, there's already